Hi, everyone. Thank you so much for joining us today. My name is Haley. I use the pronouns she and her. I'm a project officer for CPHA's Substance Use Project, and I will be co-moderating the webinar today.
Hi, everyone. My name is Karen Moen. I also work at CPHA on the Substance Use Project, and I'll be helping out in the chat and with the Q&A. So yeah, if there's any issues, please just let me know. I appear as CPHA webinars in the chat. So thanks.
While we are working remotely, I would like to acknowledge that CPHA's office is located on the original, unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and CPHA is grateful for their example their stewardship provides. CPHA is committed to working with First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. So now for a bit of housekeeping. All participants are muted, but we hope to engage you throughout the webinar through other features. If you have general comments, please post them in the chat box in the toolbar at the bottom of your screen, visible to all participants. If you have any questions for the presenters, please post them in the Q&A box, visible to all presenters. The format for this webinar will involve a series of discussion questions that will be answered by each panelist, following by a question and answer session at the end. If you think of any questions during the panel discussion, please drop them in the Q&A box and we'll try to get to them all in the final half hour. This webinar is being recorded. The recording will be made available on CPHA's YouTube channel. Okay. Once again, thank you for joining us today for this panel discussion entitled Reflections on a Public Health Approach to Substance Use. This webinar marks an opportunity to explore the gap between public health theory and practice and what a public health approach should aim to achieve. Earlier this year, CPHA initiated our Substance Use Project, which will run until December of 2023. Since our project focuses on building capacity for a public health approach to substance use, we thought it would be good to start a Normalizing Conversations webinar series by reflecting on what that means, to think critically and question our assumptions when we talk about a public health approach. Please stay tuned for updates on future webinars in this series. Okay, now I'm happy to introduce our amazing panelists. So first we have Gord Garner. Mr. Garner is the Executive Director of the Community Addictions Peer Support Association. He is a national public speaker and trainer on addressing stigma and person-first language. He is living well with his own substance use disorder at this time. He is dedicated to removing barriers to enable policy writers, academics, researchers, and people with experience of substance use disorders, active or in remission, to take evidence-based actions to improve the lives of Canadians concerning substance use. We are also joined by Ashley Hyland from the Community Addictions Peer Support Association, and I would like for Ashley to introduce herself now, if she doesn't mind.
Sure, thank you for that. My name is Ashley Hyland. I'm the office manager and project coordinator for the Community Addictions Peer Support Association. I've been with CAPSA for a little over a year and a half now. It definitely increased my knowledge around stigma related to substance use and person-first language. I've learned endless amounts of knowledge from Gord. So I thank Gord every day for how much he's been able to teach me around this topic. And I'm very glad to be able to be part of this today. So thank you very much for having me as a participant.
Thank you so much, Ashley. Also joining us, we have Scott Harrison. Scott is a registered nurse with 30 years of clinical experience focused on marginalized communities. His professional role is Executive Director for the Urban Health and Vancouver Coastal Health Providence Healthcare Integrated Substance Use Programs. He is also continuing his training with an MA in psychotherapy. Elena Hasheminejad is an acting manager at York Region Public Health on the Substance Use Prevention and Harm Reduction Program. Elena has over 7 years of experience working in the Substance Use and Harm Reduction Program with a primary focus on the cannabis portfolio. She has had the opportunity to participate in federal and provincial consultations for cannabis legalization and regulation. Elena is also a clinical teacher at a local college teaching community and population health nursing. She holds a Bachelor's of Science degree in nursing and a Master's in education. Elaine Hyshka is currently appointed as an Assistant Professor of Health Policy and Management in the University of Alberta's School of Public Health. Her research spans both health services and systems and population health pillars and focuses on advancing a public health approach to substance use. Her program leverages her interdisciplinary background and diverse methodological experience to generate new knowledge that advances health systems innovation and improves health outcomes. Her research team has a core engaged scholarship orientation, and their work is conducted from start to finish in partnership with people with lived experience of substance use, poverty, and homelessness, healthcare providers, health authorities, civil society organizations, and governments at all levels. Welcome to all of our panelists, and thank you so much for joining us today. So now we will get into the panel discussion with our first question. We're seeing more and more dialogue around a public health approach to substance use in Canada, including a new project we are taking on here at CPHA. We're starting with the understanding that employing a public health approach means our work should be grounded in principles of health equity, social justice, and an understanding of the determinants of health. But we're interested in knowing, what does a public health approach to substance use mean to you? And what should public health be striving for? And I'd like to start off with Elaine for this question.
Great, thank you very much. And I just want to say it's a privilege to speak today and be on part of this panel with so many great guests, as well as to see so many people interested in this topic and attending. So my basic academic career has been dedicated more or less to advancing a public health approach to substance use in Canada. And I think it's long overdue that we adopt such an approach. To me, a public health approach is grounded in scientific evidence, and it's based on principles of social justice, human rights, and equity. I think core to the approach is to recognize that there are harms and benefits to all psychoactive substance use. And so this isn't just about trying to minimize negative harms. Like, we also need to acknowledge that people derive benefit from substances in their lives. I'm deriving benefit from this coffee that I have here. Other people derive benefit from other substances. So I think a public health approach is trying to balance the risks and benefits of substance use, and at the individual level, and also at a population level. To me, public health is focused really on promoting health and health promotion and protection, rather than on preventing all substance use. I think a lot of the trouble we've ended up in the current situation with the overdose epidemic and extreme rates of morbidity and mortality related to alcohol and other substances, that is, to me, it's not because we're not guiding our approach to using evidence. And we, especially on the illegal drug side, we are, trying to prevent everyone from using illegal drugs. And I don't think that's feasible, and I don't think it's appropriate. And so to me, a public health approach is about trying to tackle and focus in on harm and minimize harm at a population level and an individual level, recognizing that people use substances for a variety of reasons. Beyond that, I think, if we're talking about what public health should be striving for, when we look at the evidence and we look at policy, we know that the preponderance of resources in Canada and internationally that go to addressing substance use is focused on criminalization and punitive approaches. And that's particularly true for illegal drugs. And as a result of that, those investments that are going to the justice system are undermining our capacity to promote health and to protect population health. And it's diverting resources away from the health system. And there's a whole large body of evidence now that shows that those punitive approaches are not particularly effective for deterring use, and that they come with their own whole host of harms. And so to me, a public health approach needs to acknowledge that, recognize the harms, not just from substances, which, they exist. There are harms from all psychoactive substances, but also recognizing that our policy approach can exacerbate harm, and that we need to do our best to ensure that the actions we're taking are not exacerbating harm. And so I would say in Canada, core to a public health approach, or adopting a public health approach, would be shifting resources away from criminalization, punishment, incarceration, and moving those towards the health system and the health sector, so that we can support people to be as healthy as they can be.
Definitely. Thank you so much for that great and comprehensive response. I'll move to Elena next.
Wow, I think Elaine just nailed it on the head. I don't know if I have anything valuable more to add, but I can speak to very similar themes that were highlighted. When I think of a public health approach, I'm thinking of substance laws and policies that really prevent, reduce, and respond to the potential harms of substances, but also really respecting human rights and promoting health and well-being. I think they're really stemmed on principles and strategies that support healthy individuals and families and communities. And like Elaine mentioned, it's really understanding that there are benefits to substance use as well, and not taking the approach of just looking at the harms. I really think that they're committed to, social justice, opportunity, privilege, human rights, equity. We want to take a public health approach by using evidence-informed policy and practice, and really understanding that substance use is a health issue and not a criminal issue. And I think it's, a webinar like today and many of the discussions that have been happening more recently and even in the last few years really highlight that. It includes health promotion, health protection, population health surveillance, but it really recognizes that, substance use can often be symptomatic of underlying social or health issues and inequities. And by taking a public health approach, we're really balancing all those factors when we're looking at health and well-being.
Great, thank you. Yeah, that was definitely. I'll move to Gord next.
Once in a while you kind of feel inadequate, but I'm going to do my best anyways. And so I'm still sort of recovering from the mister thing, but I got a mirror here, so I know what you're talking about. Anyway, so a public health approach to substance use, and I think health is the key word here, right? And I think that we're talking about people's health and wellness, then we need to have that as our conversation piece. There are predators in this world that create and make substances for the harms of others to profit from. So that's a true story. I know that story. And so I think there is a role in society for public safety. But if the goal of public safety is safety and wellness, then there's quite obviously you would extrapolate from that the need for change. But not the need for full elimination because of the nature of predators. Another substance will come and predators will prey on people. And, I've seen that in my life, and so once you've seen someone, and old joke from when I was in my 20s, so 40 years ago, somebody once said to me, how do you buy a big house, Gord? 2 rich kids and a needle. How do you buy a neighborhood? 2 chemistry students and a needle. And so those folks live in this world, and we need to have some protection socially around us for that. I've also had friends since I was 16 in jail around substance use. And so I'm not a big fan on hurting people around their substance use, but it's that package there. The other thing is that we don't want to confuse substance use with poverty. Because it's not the diagnosis of substance use disorder does not have poverty as a diagnosis. And so poverty has its own harms. We need to address that. I've lived outdoors. I know what it's like not to have a key to any doorway, but I've also lived indoors and found no comfort in a comfortable chair. And so we need to know what treating a substance use disorder looks like versus treating poverty. And we need to realize that most Canadians are indoors, not accessing healthcare services. So there's an irony here that our impoverished community of substance use people often absorb major healthcare dollars because they're getting the wrong services, then they need to improve their quality of lives. And there's no doubt about that, but they're engaging with the health system regularly. But by far the majority of the population who's actually insured, secure housing, secure food supply, can't access help because of stigma. And so some of the greatest suffering through stigma is not in fact our homeless population, but it's our housed population who can never say they're ill because of that. And so when we talk about who this is, a public health approach, we need to make sure we're including the public. And probably the leading component of that would actually be police services across the country who have incredibly high rates of substance use issues that go unreported and are the farthest away from receiving help, being a great irony. So what does that look like? It looks like understanding. I heard very clearly some things that I just love is that most people are seeking health. They're seeking well-being, and substance use is about seeking an improved health condition. It may not be effective, it may be misguided, or it may be effective, we don't know, but it's a question we need to ask people about their relationship with substances. Is that working for you or not, right? And the presumption, it cannot be that it's not. There's a reason for the use, and there's a reason for the seeking of the use. And that can be multi-layered. I think one of the other key components in my mind, and someone will have to press the buzzer when I'm supposed to stop, is that we have to understand that most violence in Canada is unreported. And so our belief about who's experienced violence is greatly you can't see it. And so when we're looking at adverse experiences for people, we cannot assume that housing and income security and food security is a sign that no violence is taking place. And so the vulnerabilities exist across our society. What should we be striving for? We should be striving for, I have sort of 4 quick things here. Prevention isn't really about preventing substance use, it's about preventing harms. Is it really about increasing wellness of Canadians around substance use? And that's that whole continuum. Some Canadians won't use any, some will use some will use too much, but we want to increase health around that. If treatment isn't really treatment, it's just some momentary harm reduction in education that often involves recurrence immediately afterwards. Why call it treatment? It confuses everybody. Why don't we call it part of increasing wellness as a continuum? And if harm reduction increases people's wellness, why don't we just say that? And then Canadians don't have to be educated about what a harm reduction strategy is. They already support increased wellness. And again, if enforcement is intended to increase the safety of Canadians, then let's examine it through that lens and ask people if we're increasing the safety of the people in Canada using substances by the policies that we have. And so a new language for the 4 pillars, and I think public health can help lead that charge into that new conversation. And I guess it's difficult because everyone has been struggling to get recognition for their pillars' purpose. And if we can let go of the pillars, we can hold on to each other's hands and make a better world.
Oh, thank you so much for your response, Gord. That was amazing and very comprehensive. I'll move to Scott next.
Again, difficult to follow what everyone's already said. I think Elaine's point is very well made, which is that we tend to view substance use, the way it's articulated and mediated, as it's just one structure, and it's often understood at the individual level. And I think from a public health perspective, public health calls us to look at not just the micro individual level, but the meso and macro levels as well of society and of health. And yet we often articulate substance use as a disorder to begin with, rather than a range of behaviors along a continuum, and what is socially acceptable substances to use and what are not socially acceptable substances to use. So again, that brings into like the issues around criminalization. What drugs do we think are okay, like caffeine and alcohol, and what aren't? A good example of this is that I manage Crosstown Clinic in the downtown east side. We were the first heroin-assisted treatment clinic in North America. Coming from Europe as an immigrant, heroin-assisted treatment is regulated and is out there, but in North America, you mention heroin and people run for the hills. So, and that's largely because of the way that it's been mediated. I think also we need to, from a public health perspective, look across the lifespan. We are starting to use evidence better with regards to treatment of substance use. However, what we don't, the evidence that we're not using is the stuff that we have in so much information now around adverse childhood experiences. So this research has been done again and again and again, and we know that the more that children are exposed to adverse childhood events, that it triggers epigenetic changes, it triggers behavioral changes, exposure to stress hormones, and they're all related to ongoing adult problematic substance use. Yet we don't routinely screen children for ACEs or do any kind of early intervention. So the majority of our healthcare regarding substance use is pulling people out the river rather than stopping them falling in the first place. So we need a better structure for dealing with substance use, which starts with, in childhood, supporting families, issues around poverty, education, access to services, tracking and following children who are experiencing trauma to provide them with trauma counselling. There's a lot that can be done before the more expensive therapies are required later in life. So for me, that population focus and the public health approach is trying to move back up the river. So we're not investing enough in early childhood and support of families. We're reinvesting much later down the road.
Great. Thank you so much for your response, Scott. And we will move to Ashley to round out this question.
Hi, sorry for the confusion. I'm just listening in for Gord today. I wasn't participating as a panelist. So I didn't have anything prepared, so I do apologize for that.
Okay, no worries. Sorry about that. Thank you.
Thank you. Thank you.
All right. Thank you to all of our panelists for your responses. And I think that really speaks to the need to expand the range of services available and allow people to have choice and control over the care that they're receiving. Okay, so we'll move on to our next question. So I want to talk a little bit about current gaps in public health approaches. So what are some of the ways public health might fall short of addressing the needs of people who use substances? And are principles of health equity and social justice currently informing the policies and actions that impact the lives of people who use substances? And I'd like to start off with Scott for this question.
I think that we are starting to use the principles of health equity and social justice. There's certainly steps in the right direction regarding that with some of the policies that are coming out now. Specifically looking at some of the structural and systemic issues that lead people into substance use disorder and then keep them trapped there. The way that certain agencies are funded, the way that things are done, the policies, sometimes we unknowingly trap people in a kind of a cycle. And certainly within neighborhoods as well, where there is problematic substance use. I think it's some of the ways that we're falling short. I've been a Canadian for 14 years now, but I'm still kind of stunned at how health professionals are expected to be apolitical. And there's a lot of work done within health authorities to ensure that we don't upset a ministry or we don't upset a minister. And our healthcare policies are kind of tied to the provincial and federal election cycles, which I don't think does anybody any good because it's all ideology based. So particularly around substance use. So we kind of get the wind beneath our wings a little bit and really sort of move forward in one direction. And there's always the fear of then, well, if we now get a Conservative government, what's going to happen with this? So we're kind of, rather than having a blanket approach like we would to oncology, for example, we're tied to political ideologies around substance use, which is scary at the end of the day. And it's not a very good way of delivering healthcare. So I think that where we're falling down in public health is our willingness to disrupt the system rather than just kind of keep the system going. It needs to be disrupted, and we need to ensure that governments, federal and provincial, are held to account for ongoing funding and support of substance use services in the same way that they would be for surgical services or oncology services.
Thank you so much for your response, Scott. And I think that's a really great point. I'll move to Elaine next.
Elaine or Elena? Sorry, I didn't get that.
Sorry, Elaine.
I had a feeling this would be an issue with our similar names. Yeah, I totally agree with Scott. I think it's really interesting because if we look internationally, harm reduction, prevention, treatment related to substance use is often very heavily siloed, including in Canada, outside of mainstream healthcare. And that is a process of stigmatization, right? Like that is, like we are saying that this set of health conditions related to substance use are not somehow, you know, deserving of the same level of care as people with other health conditions. And I find that extremely frustrating. And, you know, a lot of my research is focused on trying to understand how we can better integrate those services and approaches to care into mainstream healthcare. And we see a lot of resistance to that. Like, and, you know, at the end of the day, the healthcare system is a representation of society. And so you will see people in that system that will continue to enact stigma against people who use substances because they were raised in a society where that is acceptable. And I think that that's a huge challenge that we face in trying to better serve people and to better care for them. So that's one point. I think Scott also alluded to the fact that in Canada in particular, we have a pretty weak public health system, generally speaking. It's definitely varies according to legislation and provincial jurisdictions. But for example, in Alberta, we have amazing public health leaders, but they, at the end of the day, report to the Minister of Health here. You know, there is no independence for them really to enact the best strategies for a public health issue like substance use. And so we really do see it heavily politicized as a result of that. And I find it frustrating, and I can appreciate why this is the case. And I don't blame people working in the public health system, but I do find it very frustrating that public health professionals seem to like to avoid talking about substance use as much as possible. Like, you know, there are some certainly that are very outspoken, and we can look across the country and see public health heroes that are advancing the agenda and are calling for change. But we also, for every one person that's like that, I think there's 10 public health professionals that would prefer not to engage in that conversation. And I think it has to do with the fact that it's controversial and it's political. And that's really unfortunate because it's, you know, before the pandemic, I would have said, like, this is the defining public health issue of our time right now in Canada. Like, we are losing, you know, so many people, thousands and thousands of people every year to overdose. It's so bad that we're seeing a reversal in life expectancy trends where they're stalling out in Canada and actually declining in the US. Public health should be all over this. This should be top of mind. Every person trained in public health should have literacy in this issue and know exactly how to fix it, or at least what approaches to take to move the agenda forward and to help people. And we don't have that. And I just find that very, very frustrating as someone who works in this space, because my public health colleagues, they understand health equity, they understand health promotion. Why are they not, you know, ringing the alarm and doing everything they can to change the system and to make this an evidence-informed response and fighting back against politics and controversy? So I think that's kind of where we're falling down. But I do think it's a bigger conversation than just substance use. Like, generally speaking, I think the pandemic has really shown us that we need some better public health governance, independence, and public health structures in this country to ensure that we can, as public health professionals, practice to our full scope and, you know, promote, do our jobs to protect the population health, right? And so I hope that CPHA, I actually know that I think CPHA is engaging in those conversations. So, and I'm glad, you know, I think that bleeds into this topic too, right? And I'm happy to contribute to those conversations too, because I think at the end of the day, we need a really strong public health infrastructure in this country if we want to achieve health equity and protect people's human rights and their health.
100%. Thank you so much. That was amazing. I'll move to Elena next.
Thank you. I echo Elaine, I echo Scott. I think what I'm going to add on, and I like I said, I can't speak more of what they've shared. It's definitely something that I wanted to highlight. But if I put on my local perspective on and just think of, you know, my role as a public health practitioner within a local health unit, and there may be others on the line who have, you know, similar roles. I think one piece that I could speak that we fall short on in public health is not involving people with lived and living experience, and not involvement at the point when you're trying to distribute a service or deliver something. Involvement in the very beginning stages when you're talking about planning, when you're looking at a situation when you are just having those initial discussions, I feel that, that is something that, again, there could be many that are doing that from the very get-go and for many, many years. And I'm just speaking from experience that is something that I feel public health falls short on. And I feel it trickles down into many layers of, when you even think of wanting that expertise and feedback in your program delivery and planning, but then not having budget from the very get-go to have that as part of planning, right? From a systems perspective, it's not just involving individuals to give their experience as part of planning, but then you need to, from the very get-go, already have budget and finances that support that. So I feel that that's something that always really sticks with me. Some of the greatest lessons that I have learned as a practitioner and continue to learn are from individuals with lived and living experience. And I think that's something that public health falls short on. And that ripples down into stigma, right? So I think that's another really big piece that, we speak about, but it's such a barrier to wellness. And, even as a clinical teacher, and I think of, nursing students, we don't talk about stigma in population health. We don't, these are things that you would think that from the very get-go in education, you're providing that as part of people to learn in the field of public health, whether it's a frontline nurse, whether you're working for a public health unit. These are discussions that need to happen. Self-stigma, social stigma, structural stigma, how that contributes to shame, how discrimination, and even if it's unintentional, prevent people from getting the support they need. So I feel that those are pieces that, more work can be done around it. And, like Scott alluded to in the beginning, are principles of health equity and social justice currently informing policies and actions? I think we're starting those conversations more. And that is not to take away from those practitioners who have been doing this for many, many years and have that at their forefront. But I think we have quite a way to go when we're talking about health equity and social justice really informing our policies and actions.
Thank you so much for that perspective. Yeah, definitely. And I'd like to move to Gord next.
It's really nice to have this conversation. My head gets listening to everybody and I go off in a direction. And so it's very nurturing. So I just want to recognize that for sure. So one of the ways I think public health is falling short is it hasn't made it about public health. It hasn't made it about Canadian health. It's made it about health of people using substances. And that's such a small piece, eh? And then of course, it's those people over there that we can see that we're talking about, isn't it? And so we keep narrowing that. The irony for me, we live in I work in a psychologically unsafe environment on a daily basis because we work to address stigma and confront it where we can on a daily basis. And we're often working with the good-hearted, and the unconscious, right, about the stigma they're participating in. And so 60,000 Canadians died from substance use last year. 500,000 grieving Canadians around substance use last year. And yet all I hear in the newspaper is about the 5,000. Right? And then I hear those 5,000 that are influencing the lifespan of Canadians. Well, what about the other 55,000? Were they not young enough? They're not vulnerable enough? Were they not something enough? And if we put them on a bicycle and we gave them a hockey stick and then they passed away, would Canadians rally around? Right? Is there, homelessness, right? I have this little message about homelessness. When I was growing up, it was considered really like you couldn't drive by anybody in the ditch in the wintertime, no matter how stupid you thought they were for being in the ditch, because they could die there. And now we have a homeless population of 250,000 people on a monthly basis living outside. So we need to get them in a car and put them in the ditch so that we have our manners again. What happened to cold weather kindness? So we have a compassion crisis in Canada. We have a public health crisis in Canada, but it's not substance use, it's compassion. It's not the 250,000 people without housing, it's the 33 million people that allow them to live outside. And that's a public health approach. What is wrong with the health of Canadians that this is okay? What's wrong with the health of Canadians that we're allowing people to die using substances that they can't not take? And again, the misdiagnosis sometimes, the majority of Canadians are dying from overdose, not because the drugs are dangerous, but because they can't not take them. They've lost the ability to self-protect. And so that's the piece there, right? And then you hear, I get excited, people talk about compassion fatigue amongst first responders, right? And it's like not compassion fatigue, it's control fatigue. They want their actions to have a control in the outcome of the other person's life. So they don't understand the difference between reversing an overdose and treating a substance use disorder. Right? Because to them, geez, if you just about died, you'd never do that again. Meanwhile, the person that reduced overdose is really angry, they're dope sick, they're in pain, whatever behaviors they had to acquire the substances, they have to repeat now. When they have to repeat it while they're really sick, it's just confusion, right? Because we don't understand what the problem is, And so, which is where, again, our health system comes in. If I went to the hospital today with a reoccurrence, they would say, oh, Mr. Garner, you got a history of drug seeking here. And so whatever we do, I want you to know you won't be getting any medication today. And if I had emotional difficulties or behavioral issues, and I continue to use substances, they would send me away as non-compliant to treatment for the very reason that I took myself there. Because our health system is set up on the basis that consequences change behavior. And of course, people with substance use disorder, the very diagnosis is that the consequences don't change the behavior. So that whole thing, but if we don't involve the general public in this issue, nothing's going to change. And I love the conversation about there's something wrong with the box. And we can spend a lot of energy trying to work really well and effectively in the box, but the box they gave us to work with around substance use is too small. Yes, we need to intervene, and we need allies, and we need the 500,000 grieving Canadians to be able to speak up, and they don't because internalized stigma about why their loved one's gone. So health equity, social justice, again, I've learned a lot in my life about in privilege that I have. I used to tell a story about how I bought and sold drugs for 40 years and never got caught. And now I have to add in the fact, oh yeah, I wasn't Black. Maybe I wasn't the smartest drug dealer after all. Maybe I just was white, And so there's layers to this, and they're exponential. My family has a long history of multiple suicides and addictions and deaths, but we never did that as an Indigenous community member. All right. So our experiences are not all the same. And when we're talking about including people with lived experience, we need to realize that there's so many of us with all our different and unique experiences. We're really limiting in that. We're also saying, nobody's saying to us, right? We want to engage your skills. If all we got is that I used to use substances, what does that do to add into the conversation? That is great for input in a survey about how to improve services, but if we're talking about system change, we need to bring some skillful people. And I want to tell you right now, they're already in the building. They're down the hall from you. They may be sitting in your chair. I don't know. Nobody has to put their hand up. But why do you think so many people get interested in the health field? Okay, because they're lived and living experience and they got family members. We're here, we're educated. I'm not, but I know they're out there, and we're beginning to attract into CPHA who can bring not just their experience, but their skills informed by the passion of their experience to make differences. But until we start talking about what skills do you have, right? Then we're really just saying, oh, you're someone who uses substances, past or present. And that's pretty limiting. Anyways, there's my little passion pitch.
Thank you so much.
If I could add to that, Haley.
Yes.
Absolutely. God for Prime Minister. So true. But when we think about social justice, we always think about it as this entity that's external to us. It's this kind of thing that we do. When I do training in my hospital with my staff, I always ask, stand up if you will be willing as an Indigenous substance using woman to come into our emergency department. And no one stands up because they know what happens. They know it's not good enough, but no one does anything about it. So it's not just about being aware of social injustice, it's addressing social injustice. And that means having difficult conversations with our colleagues. It means having to have difficult conversations about misogyny and poverty and homelessness and who is classed as a human and who isn't. Here in Vancouver, on one street in Vancouver, we have the lowest earning postal code and the highest earning postal code in the country on one street. So you can literally drive 2 kilometers from Yale Town into the downtown east side on one street. Now at one end, the drug use is alcohol and cocaine, and that's acceptable because it's being done in Yale Town condos. But the fentanyl and the junk drugs that are only available in the downtown east side are at the other end of the street, and we find that culturally and socially unacceptable. And for Vancouver, my question is always, for Canada, we're a Western, relatively rich country. How is it possible that we allow people to sleep in tent cities? How is that possible? But we do. When, God forbid, the 737 MAX aircraft was pulled from production because 2 of them crashed and tragically killed over 300 people. One of those effectively crashes in BC every month with overdoses. And yet we're still scratching our asses and saying, well, what should we do? Like, we have to actually take action.
Thank you so much, Scott, for that very powerful response. And thank you all for speaking to the really systemic changes that need to happen both in healthcare and public health and in society kind of more generally at large. So we'll move into our next question now. So now I want to talk a little bit about best practices. So what would you consider to be some best practices in public health or outside public health that are really protecting and promoting the health of people who use substances in communities? And do you know of any examples of current public health approaches to substance use that are working well? And I'll start off with Gord for this one.
Holy cow, I can't build on the others. So safety. I mean, it's not a big word, but it's pretty complex, right? If what we have in Canada is a safety issue around people that use substances, they're unsafe to tell their stories, whether they're experiencing pleasure, whether they're experiencing harm, whether it's a past experience or current experience, that is silence. So that's an unsafe environment to live in. And we know that the experience of not being safe is hard on our brains and it's hard on our mental health. And so it's a compounding issue that continues throughout the lifetime of someone who has a history of substance use, current, present, or past. So how do we create a space to have a safe conversation about someone's relationship with substances? Because that's what we're really talking about, right? I have a healthy relationship with the substances that I'm using. And so, and that would be something that was personally definable for the person that's doing that. And then what's that look like? Who's involved? How do you create that? And safety for many people, it means many different things. And so that's, I think, where you go with the lived experience that's really important is you find out when they begin to report feeling safe, right? And I think that's the experience we're looking for, right? Is, did you feel safe at the supervised site? Did you feel safe at the doctors? Did you feel safe in your interaction with the police? Did you feel safe when you were walking down the street, you know? And if we use that as the touchstone, right? And then people look at their health around their feeling of safety, right? Not whether I got what I want in the world, not whether I'm happy because it's raining outside, but whether I feel safe becomes the foundational point of health for all Canadians, then we will know how to treat each other. And we will treat each other differently than we do now, because we will consider with what my actions are creating safety for the other person. And then again, we get into that public space, right? You know, I want to acknowledge that my behaviors during my active substance use were abhorrent towards many people. I caused a great amount of harm. And so I know that I created lack of safety in many people's lives during those days. And so that's also part of the true story. We don't want to make up any unicorns here, right? Because we won't take ownership around some of that stuff. Then we can't move to this other conversation, you know, and I see that as part of my health issue. And how do I know that? Well, because I don't do that anymore. And people feel safe around me now. And so and it's not related to the substance use, it's related to my behaviors associated with the substance use and my particular inability to consider others and my desire to have more. You know, and so that was a health issue for me.
Thank you so much for your perspective, Gord. I'll move to Scott next for this question.
Yeah, thank you for that, Gord. It really speaks to the need for us to have those conversations around safety. I also think that some of the best practices that we could quite quickly give people access to are things like trauma counselling. Now, not everyone who's been traumatized used substances, but I would argue that everyone who used substances is traumatized because of the processes often that they need to go through in order to access their drug of choice. I know that in the patients that I care for in Vancouver, there is multiple layer after layer after layer of trauma often that has never been addressed. And even though healthcare providers are often trying to do their very best, there is a lack of understanding in the general healthcare professions around trauma and around triggering someone's trauma responses. And access to counselling is great as long as you've got extended health benefits and full-time employment, or you can pay the $140 an hour to see a counsellor. So I think we could redeploy some resources into psychotherapy and into counselling. Certainly that's what's driven me to do another master's degree in psychotherapy, is to be able to offer counselling that is, you know, free to people who are traumatized, because there just isn't enough supportive services. It's not just about the drug. It's in our rapid access clinic, as an example, it's very easy to provide someone with a replacement, particularly with the new guidelines around prescribing during a pandemic. It's everything else that that person needs as well. So it's often the disconnection from family that they're suffering from, inadequate or no housing, poor food security, not feeling safe generally. So the requirement is to have this kind of wraparound service. It's not good enough just to offer someone methadone. We have to also offer the other supportive services until that person is back on their feet. And we have to be able to work with someone around their resiliency, because every substance user that I work with is enormously resilient. By the sheer fact that they're stood in front of me demonstrates their resilience. And so how do we work with someone on their resilience and just give them the tools and skills and basic physical support they're required to succeed?
Sorry, my turn to get excited, Scott. So I just sort of remember all the times I went somewhere and some well-meaning counselor took me into a small room and closed the door because he thought we'd be safe in there. Yeah, no. Anyways, thank you.
Thank you both. And thank you, Scott, for speaking to the issues of health equity in our system and that a lot of people can't access services that should really be provided to constitute comprehensive health care. So I will move to Elaine Hyshka next.
Yeah, and thanks Scott and Gord for their points. It's hard to build off that. I think there are a few things I would say, like at the end of the day, we know when we look at the evidence that it is relatively a small proportion of people who use illegal drugs that run into problems with them. And so I don't want to lose sight of that. Like not everybody is going to require, you know, like a lot of people use drugs, and Scott made this point in terms of like the Yale Town and like the idea of cocaine and alcohol. Like a lot of people just integrate substances into their life and it doesn't really cause them too many problems. And so I think public health needs to be responsive to that population too. Like we really do need to think about this as a pyramid with the broad base of people that are not really experiencing harm, but maybe could benefit from reality-based education about what, you know, what they are doing. And ideally those people, in my opinion, would have access to known quantity of what they're taking and not have to go to an illegal market to purchase it, and you know then society suffer the consequences of encouraging and promoting those illegal markets. So I think like we need to have that, we do need to take that perspective. When we talk about best practices, I do worry sometimes because we don't have a lot of good evidence on what to do in this space. Like we can't, you know, a safe supply is a very hot topic, and Scott mentioned it in terms of the pandemic prescribing. And I support the idea of safe supply, and I think that we need to move in that direction very quickly and see how it goes, and then adjust our approach as we do that. But there is, you know, if we look at, like, there really isn't evidence to show that distributing hydromorphone tablets or prescribing that way is necessarily going to achieve all the outcomes we want it to achieve. And so I think public health needs to recognize, like, we're not always going to have evidence. Like, so what we need to do is take the evidence we do have, which is things like criminalization clearly causes harm. The legal street market is getting more and more toxic every day and leading to increases overdose. Like that is evidence too, that then we can use to inform innovations. And we need to be flexible and recognize that those innovations may work and they may not work, but we have to be brave enough to try them, I think. And so if we're going to advance the public health approach, it's not just about like, let's sit around and wait until the science catches up and now we feel confident we can do these things. Like we really have to be brave. Like the current situation is not tenable. And so I would say, to me, the best practices that's happening is the jurisdictions in Canada, and including at the federal level, where they are willing to stick their necks out and say, like, this is something that could backfire. It could be really good. We don't know for sure. We are going to try it because what's happening now is not working. And so I'd say that. I think too, more generally, we have like pretty good evidence showing that universal prevention programs do prevent a whole host of harms. Like, and you know, the most effective way to prevent substance-related harm is to intervene at an early age and not even talk about drugs, right? Like people don't necessarily need drug education or like this DARE curriculum or whatever. Like we just need to promote people's health and promote young people's ability to have healthy peer norms and healthy culture, have attachment to their parents, like these kinds of things. There is good evidence showing if you intervene early on, that is a protective factor for not just preventing, you know, problematic substance use or substance use disorders, but also for preventing like a whole host of potentially negative health outcomes for people. And so I would really like to see like a lot more investment in those kinds of approaches in terms of turning off the tap. I think that'd be really valuable. What else for best practices? I think I would say this is kind of like a mundane point, but like information is power. And in public health, because we do surveillance, have a lot of power in terms of the data we have. And it's very frustrating to me when we can't have good and timely access to that data. And when there is disputes over how that data can be shared and with who. And, you know, I think if we had, I think like one way we can actually make a difference is by trying to break down some of those barriers and trying to ensure like that we can share information widely with people and not see it as like organizational divides where like, oh, you're not in the health system, so we can't tell you this. But, you know, I think that's really important, and it's actually overlooked because like people just think, oh, well, it's just paper, but those, like, having data is how you make your case for change. And it's also how communities stay informed about what is happening in their populations and with their people and how they can keep each other safe. So I think that would be another best practice. I think I'll, leave it there. Those are more like, probably more like boring suggestions, but compared to Gord and Scott, but I think they are practical ways that public health could be improved.
No, thank you so much. And I'll move to Elena now.
I'll just add the last bit of boringness then, because I don't think Scott, Gord, or Elaine, you guys did anything that was boring, brought some really good points. Again, I'm learning so much hearing just from the discussions that are happening right now. And I just think to myself, some of the practical strategies and best practices that we can do locally that sometimes gets missed is something as simple as harm reduction practices. You would be surprised, across the board, nationwide, how that is still a foreign language to some, meeting people where they're at, providing practical strategies, things even like needle exchange, safer smoking inhalation supply distribution. These are things that some of us at the local level have struggled getting access to or buy into to be able to have as a strategy. And I remember something that stays really close to me is one of our members of the Harm Reduction Coalition once, stood up and very bluntly said, it's very easy for you guys to talk about harm reduction, but you don't actually believe in the philosophy of harm reduction. If you do, every part of every service that you deliver stems from that philosophy. So it's, that questioning of, best practices is of really where, like, what do people need and where do we meet people where they're at? And, it can even, when I think of just from a public health perspective, health promotion for us is a really big best practice topic area that, we focus our energy on, helping people make informed choices. But a lot of the time we're leading those discussions with trying to change people in their choices that they make. That's not health promotion. We need to be able to, information and knowledge is so valuable. And, going back to Elaine's point, not being able to share or have access to data, sharing that to the community, giving information so that people can make their own decisions. I think that's a really big, loophole and a best practice that we need to stem forward. I think one thing I'm really interested and excited to see, where it goes, and it could just be from some of the policy related work I did on cannabis, is that I'd like to see that direction of where in a few years down the line, what evaluation will look on that. A lot of work went into many people from different areas advocating for a public health approach, really highlighting to professionals that, we need to be taking an approach that proposes supply and demand is best controlled, and social and health problems are really at the lowest when extremes of complete prohibition and maybe free market of legalization are avoided. But really going back to that best practice strategy of the paradox of prohibition, I'd really like to see that, all that work that has gone into cannabis legalization and regulation and driving that factor, what that would look like. So I think that would be a discussion that would be interesting to have, a few years down the line of how that best practice has resulted when we look at that topic area.
Thank you so much, Elena. And now, for the sake of time, I'll move into our last question before the panel discussion. So, before the question and answer period. So moving forward, what would you like to see public health professionals to consider moving forward? And what is one question or point of reflection you'd like to leave us with today? And I'll start with Elena for this one.
Sure. I think something that Scott said to me really stuck with me today, and I would just reiterate it, is take action. And self-reflection in work, no matter, personal, professional, where you are as a participant today, being able to self-reflect on your own values, your own biases. Where are your blind spots, your beliefs when you're talking about substance use and harm reduction? Does that impact the work that you're doing? Are you someone that's doing service delivery, but, has stigmatizing language in the work that you do? So I feel like if I could just, reiterate anything or something that really sticks with me in my practice is that we have to be open to hearing, listening, reflecting, and taking action. Just myself today, listening to the three panelists and just sharing their knowledge, their views, that has been instrumental for me. And I just hope as practitioners, as we move forward, that we really understand the impact of stigma. We really understand that it's really important that we continue our self-reflection and we take action.
Thank you so much. I'll move to Gord next.
Hi. So yeah, I'm appreciative of being here today and the learning that's taking place for me. My concern, I guess, is that, and again, you know, I've experienced quite a few things in my life that we're talking about today. And so, but more importantly, I know thousands of other people have had similar experiences. And so I'm kind of bringing that lens to you. And so one of the things I want us to remember is that the folks down the street and the good house with the good supply and the right kind of dope are suffering, you know, and I met them and I know them. And that's why we have private service treatment centers in Canada, because the house and the car and the money in the bank and the kids in college or whatever that might be for them has not eliminated the suffering of their substance use. So we're truly talking about, I know some people have gotten close on this. They talk about the opposite of substance use disorder is connection, and they talk about being connected to society, but we're looking at an entire population. 85% of the Canadians with substance use disorders are connected to society. They're surrounded by people. So that's obviously not the problem. It's the inability to connect with self, to be present with my own experience, my own memories, my own fears, my own emotions, to have my life experience. That's what I'm suffering from, the absolute abandonment of self. And so I always like to say, if there's 3 folks down in the market area today and they know if they hustle together, then get a bottle by 10 o'clock, fast, and if they hustle separately and they're joined in mission and they have a taste of victory at 10 o'clock, for 5 minutes, they're kings again or queens again. And the person down the street in the big house with the cars in the lane has no one. Tell me who's more desperate and lonely.
Thank you.
So, yeah, sorry. I guess that's what I want to lead the reflection on. But my other, if I can just, sorry to go on, I do have a great fear that in our good intention, that we will allow the other predators in our worlds, the ones that would warehouse us, keep us out of sight, send us our dope, keep us off the streets so they can develop their downtown cores again. That we realize that if I protected someone because I gave them a safer supply, there's been no change in their ability to self-protect. Society's had to intervene in that. And so let us not be used by others in the name of protecting their lives by warehousing us. I have a great fear that we're going to end up with a warehoused population of people that can't stop using substances, that are left without the rest of the interactions with society that they need to bear hope for them. Many of us, I mean, hope, right? You know, what that means, we don't want it to be a weight on people, but we want everybody to have the best lives they can. And we can hope for that for all of us, including myself and yourselves.
Thank you so much for that reflection, Gord. I'll move to Scott now.
I think what I would like people to consider moving forward is something that Elaine has alluded to, which is substance use is, there's substance use and there's substance use disorder. They're not necessarily the same thing. So having those conversations about health promotion in general, it's quite right. We don't need to bring up drugs as a specific when we're talking about healthy lifestyles. And what Elena said about, giving people information, like health promotion is one of our biggest pillars in public health. So just giving people information to enable informed choices. But for anyone that is working with people who are living with a substance use disorder, it's to externalize the substance use disorder from the person. So when we talk to someone about their substance use, talk about the substance, not about the person. They're two distinct different things, and we conflate them. So it's really as basic to me as recognizing this is somebody's daughter and somebody's son with very complex lives, complex backgrounds, a different worldview to yourself. But they're not just essentialized as a substance user. So we try really hard not to do that with other health conditions, yet I continue to hear it all the time in clinical practice around people who use substances. So moving forward, I would say, please externalize the substance use disorder and deal with the person that's in front of you.
Thank you, Scott. And Elaine.
Yeah, I agree with what's been said. I think I'd reiterate, one, to be brave. Like, this is an important topic and it can be very uncomfortable to talk about. And especially if you're working in an organization or part of a system that's very hierarchical, like the health system, it can feel difficult to raise these topics. But if not you, then who? And, I have definitely gone to myself into situations in the past where I've said things that, are speaking truth to power. And generally speaking, I find that most people are receptive to that if you do it in a way that is, respectful and, understands the context of your remarks. So where possible, I just say be brave. I think too, involving people with lived experience is so critical. And so I was very glad that Gord was able to participate on our panel. I think, though, it's very important that if you're going to engage with people with experience, as Elena mentioned at the start, you have to share power and you have to actually give them an opportunity to shape things meaningfully. Like, it's not enough to just say you're doing it and have, compensate people financially or whatever for their time and then send them on their way. Like, I do think we have to give up power to be able to actually enact their advice and their experience and their expertise. And we have to be willing to share that power with them. And if we're not doing that, I think we need to be reflecting on how we can do that better, because I do see very wonderfully movement towards engaging more people with lived experience, but I do worry that it's not at the level we need it to be for actually it to be effective. And we know from harm reduction, for example, the solutions come from people and then we take them and we operationalize them, and sometimes we do that really poorly. So we need to take, we need to give people the power to do that, or to be part of those decisions and conversations that affect their lives and to have the say over what happens. I think, yeah, I'd probably just leave it there.
All right. Thank you so much, Elaine. And I totally agree that that notion of giving up power is absolutely essential. So thank you for sharing that. Thank you so much to our panelists for sharing these reflections. It's been an amazing panel discussion, and I will move into our question and answer period now. We have had some questions come in from the audience. So I will start off with a question for Elaine. So someone mentioned that Oregon just decriminalized drugs. How does decriminalization fit in a public health approach? And what about a full legalization / regulatory approach?
Oh, that's a big question. I hope others will be able to chime in too, because I wouldn't say that I have all the answers. I think I totally support the ballot initiative. I think it's unfortunate it had to be something that was a matter of voting and not something advanced by the state itself, as part of government. Because I think the best practice is when policymakers can actually use evidence and inform the response, and it's not just written in a ballot initiative and then people vote on it and then that's what you're stuck with. That being said, I think it's a step in the right direction. We know that criminalization deters people from seeking care. We know that it negatively impacts their life chances when they're criminalized. They're not going to have as many opportunities to be employed or go seek education or all those things. I think also with decriminalization, we know, like, from the science, and there isn't tons of research, but the research we do have, if you look at cannabis decriminalization, for example, there isn't a really good confluence of evidence that shows, if you decriminalize, like, substance use goes one way or the other. In fact, it's quite mixed. So what we know is when penalties either are increased or decreased on substance use or on cannabis use, and this is from the European experience, sometimes use goes up, sometimes use goes down, and it doesn't really relate to the law. And so in that way, I wouldn't expect to see in Oregon that all of a sudden they're going to see a major increase in use. I also wouldn't expect to see that they're going to see a major decrease personally. I think there needs to be other actions taken, and decrim is just one piece of that, but I strongly support the initiative. I fully support the idea of moving towards a legalized or more regulated approach. I think we need to be cautious and think about commercial determinants of health. And Gord alluded to this in his early comments, that there is a profit motive, whether it's someone who's doing this legally or someone who's doing it illegally. And we, as public health professionals, it's incumbent on us to find solutions that will minimize the profit motive as much as possible, and enable safe access to substances that people want to use, but in a way that isn't promoting demand or isn't marketing and advancing like a business opportunity. And in my jurisdiction in Alberta around cannabis, it has been disappointing to see like cannabis framed as an economic development opportunity, because I don't think that's what it is, right? And so I'd be leery, and I think we should be exploring that, and we need to have those conversations now, but we need to figure out a way that's going to be not unintentionally inducing demand or increasing unnecessary exposures to substances when people don't want them or when it's not necessary. So
thank you for that really comprehensive response. I would invite any of the other panelists to respond to this question if they'd like, and if not, we can move on to the next one.
Sorry, I just feel the need to get into anything about cannabis. So when I was in grade 10, my friend and I were in the basement at his place and said, we can just get this stuff to come to bud outdoors in Canada. We won't have to cross borders anymore, and we can create a market that will eventually force decriminalization. And so we don't get enough credit for that work. However, that being said, I don't think we have to worry about promoting the use of substances. The market tends to do that pretty good on its own. I think what we really want to talk about always is the health and wellness of Canadians around substance use, whether they use them or not. And the first thing to do when they go to market is they will actually sell their stock to investors as stock pieces of paper saying, I have a piece of this. Because part of the whole scam with this thing is if I keep growing this stuff and somebody believes it's worth money, I can sell it to investors faster than I can sell it to consumers. And so that's the first profit taking that'll take place in Oregon. They'll sell to investors, and the stuff will get stocked up in the warehouse because you don't have to ship it. You don't have to actually do anything. You just sell it to investors. Sorry, part of my old lifestyle. I still get this stuff.
Oh, thank you for that perspective, Gord. Maybe I'll move on to the next question, if that's all right with everyone. So this question, I'll start with Scott for this. So substance use is part of an epidemic of diseases of despair leading to declines in life expectancy in Canada and the US. These diseases arise from the high prevalence of poverty, homelessness, unemployment, racism, and social injustice. Should we not be taking a preventative public health approach by working on policies to reduce and eliminate poverty, homelessness, unemployment, racism, and social and economic injustice?
That's an easy one. Yes, to all of the above. I think that for significant substance use disorders and access to some of the drugs of choice in Vancouver, as an example, it's all related to every point that's in that question. So we can't possibly solve, just in my own jurisdiction, we can't solve BC's drug problem just by prescribing our way out of it with safe supply. Whilst I agree that we have to do something right now to try and protect as many of the users as possible from a toxic drug supply, as a long-term policy, it doesn't make any sense. because we're just trying to prescribe our way out of a situation that has been caused by poverty, homelessness, unemployment, racism, misogyny. So unless we can start to deconstruct some of those issues in our society and collectively say, these things are not acceptable. You know, it's not okay for a major Canadian city to have a tent city and to say that that's a housing option for people. We have to fundamentally change the way that we address that conversation. And I do have this concern that by not focusing on things like criminalization and all of the social determinants of health, we're just buying some time right now, but we're also buying ourselves a bigger problem in another 5 to 10 years. Even with the safe supply issues around access to it, it's still not okay to provide someone with hydromorphone tablets because the fentanyl supply is toxic, but then not provide them with a place to cleanly use that medication. To say that it's all right for them to go into their tent in Strathcona Park without a filter and inject crushed up tablets, that does not make sense to me at all. So people need access to clean water, housing, all of those issues before we'll even get to begin to undo this problem.
Thank you very much, Scott. And I'd like to invite the other panelists to respond if they'd like.
I would just say, I think around that issue, like obviously we agree with it. And I would just add, like, I think there's a real potential to build coalitions, because there are lots of different organizations in public health and outside of public health that are working on those topics, like poverty, homelessness, unemployment, racism, and social justice, or, you know, income inequality or whatever. Like, we really need to start building up our coalitions again. I feel like we've really segmented issues where it's like, okay, these people work on drugs, and then these people work on homelessness. And it's like, it's all the same people that are suffering and struggling. And a lot of the determinants of one problem are the determinants of like 8 other problems that we're trying to fix. And so I don't know what that looks like. And I wish I had the answers, but I just really feel like, you know, we used to have broader social coalitions around topics that helped, like women's rights or the labor movement, like that really helped to advance causes on multiple fronts. And, you know, we're broad and covered multiple issues. And what I've been thinking about a lot lately, especially in my own context, my own political context, I'm in Alberta right now, is how do we get people to put their voices back together and to raise them collectively and advocate on behalf of the interests of their, you know, their collective interests, right? And I don't know how to do that, but I think there's safety in numbers in speaking out. And I really would like to see, maybe there's a role for the CPHA and other organizations that you work with to explore how those coalitions can be built again, because we all are working in the interests of health, as Gord says, health and wellness in the population. And these are all the building blocks of that. And we should be fighting for them all together.
Thank you so much, Elaine. And I think that really speaks to as well the concepts of community building and organizing and their importance. And Gord, if you'd like to chime in as well.
Just a touch, I guess if you looked at rampant consumerism and the inability to consider tomorrow, right, and look at the health of Canada as a society. Why have we not been able to deal with some of these things? Is because the most Canadians are experiencing insufficiency in their life, even as they live in privileged conditions. And so really looking at where is purpose in life? Where is this idea, these concepts of service to others in our communities anymore instead of service to self? And then it's really hard to have enough if you're afraid. And when did fear become such a big selling point in Canada, and an acceptable selling point, right? Buy this sweater because you'll look better, buy this car because people will like you, whatever that is, eh? Consumerism is coming from a lack of self-connection, a lack of self-purpose. And so you see that even where it's, you know, there's an iceberg tip here that's showing us some of the greatest opportunity to see this. But if we look closer and we see all the houses with closet organizers, and forgive me, anybody with a closet organizer, right? But evidently it hasn't occurred to us that if my closet's full, I might have enough. And so if I never have enough, how will I ever lead a life of satisfaction? If I don't have enough, how can I ever help the homeless? And so that's the issue I see for Canadians around all this sort of stuff, around justice, around employment, around homelessness, is that the majority of Canadians actually are living lives of desperation and experiencing they don't have enough, even as they're surrounded with their pile of stuff.
Thank you, Gord, for your perspective on that. I think we have time for one or two more quick questions before we wrap it up. So the next question I'll pose to the group is, how do you show unique public health perspectives at the table when other partners in the community don't think public health should be there? And please let us know if we're interpreting your question incorrectly, but essentially, how do we build better relationships with communities as public health professionals? And I'll start with Elaine for this one.
That is a tough one, because there's some, especially in organizations, there sometimes is a struggle between, is this an addiction mental health issue or is this a public health issue? And I think, you know, it helps to think about the socio-ecological model to stop, sorry for being academic here, but, you know, and the idea of intervening and supporting people at the individual level, and then leaving kind of the care and protection of the health of the population to public health. And I think that's how addiction mental health and public health can work together. It can be tricky though to communicate that effectively, but I think strengths that public health brings is that population lens, prevention lens, which, you know, there isn't tons of mental health promotion or prevention taught to people working in clinical disciplines. Unfortunately, it's very unfortunate. I think also we bring the data and we bring the surveillance. And so, you know, those are some arguments and strengths that I would say you can try to have the conversation around why public health should be at the table and why it's important. I think too, also thinking about, you know, when we're addressing substance use, we have to think about like the population pyramid, as I mentioned, like the idea of severity. And, you know, we really bring that perspective, right? That it's not just about addiction mental health primarily sees the people that have the most severity, right? Like people that are presenting for help because they acknowledge and are struggling with the problem. But there's a whole bunch of people in the population that are also struggling that maybe have slightly less severe conditions and are not being served. And that is a role for public health, is to figure out how to support those people who aren't necessarily seeking care, but still could benefit from some like intervention to some degree, or some intervention that we have.
Thank you, Elaine. And I'd like to invite responses from Scott and Gord as well, if they have anything they'd like to add.
I think as well, one of the ways of doing it is, you know, public health practitioners getting into positions of leadership and influencing those tables. I was a public health nurse and street nurse for many years and went into leadership and management as a way to try and influence the system, not because I wanted to be in charge, but to try and bring that public health lens into some of the decisions that are made in acute care and community care and addictions treatment. Because Elaine's absolutely right. The level of public health training for most health professionals is minimal. And again, it's kind of it's talked about in very kind of ethereal terms rather than the practical application of public health principles. So that is something that can really help, is to get into positions of leadership to influence those changes. And I think that it relates as well to a question that Cheyenne just made in the chat, which is you can see the disconnect between health professionals and public health by the fact that the way that our colleges and health bodies treat health professionals who have got a substance use disorder. So if we're willing to treat our own colleagues with that kind of level of punitive disciplinary measure, then what does that speak to around the system that we're actually creating to provide care for patients?
Thank you, Scott. Gord, if you have anything you'd like to add?
Yeah, I think it's a beautiful way to end, Scott. I mean, CPHA has reached out to police services and nursing and first responders in general, because we believe that unless we can reduce the stigma for those society members, we'll never address the stigma for the outliers in our society at this point, you know. And it's really, and I guess if I can just touch on tobacco, 37,000 deaths last year. And so if you want to look at stigma around substance use understand that we believe that because there's a label in the package that says this will kill 1 in 2 people that use it, that if you know better, you should do better. And it completely eliminates and goes against the actual fact that the real message is that this is an addictive substance, and people vulnerable to substance use disorder will not be able to stop and will continue to harm themselves to the point of death. And so there's that great confusion. So public health has to be part of this conversation. And I think the challenge and why people don't launch it there, if I can say it, is because they realize the depths of the problem when you're at the table. We realize how we treat our children. We realize how our society harms itself and creates ongoing costs in terms of human lives and experiences. And that we would have to live differently as a society if we're going to achieve the goals of public health. And so it's staggering for those who wish to have more than the others. And it's staggering for those who can't imagine the world that would be good.
Thank you so much, Gord, for your response. Thank you to everyone who dropped questions in the question and answer box. Unfortunately, we won't have time to go through all of them today. But I would like to thank everyone so much. Thank you to all of our panelists for your valuable insight into public health approaches to substance use. Your perspectives have been invaluable, and we thank you again. And thank you to everyone for joining us today, and we hope to see you soon. Thank you.
Let's talk, everybody. Bye-bye.
Thanks.